Good afternoon, everyone, and thank you so much for joining us today for In Name Only, COVID-19 Vaccines and Failed Promises of Global Solidarity. My name is Dina Pimenova. I'm the Senior Project Coordinator for the NYU Langone Community Health Worker Research and Resource Center, housed in the Department of Population Health at NYU School of Medicine and supported by the NYU Langone Community Service Plan. Today's event is co-sponsored by the NYU Langone Section for Global Health, NYU Community Engagement Alliance Initiative, NYU CUNY Prevention Research Center, and the NYU H&H Clinical and Translational Science Institute. Before I introduce our speaker, I would like to go over some of the housekeeping briefly. Everyone is on mute. You can enable or disable closed captioning by selecting live transcript at the bottom of the screen. The chat box is open for comments and sharing of resources. If you're trying to reach all attendees, please select everyone, not just hosts and panelists. We ask that you please use the Q&A box to submit questions to the speaker. We will have time to answer as many questions as possible during the Q&A portion. The slides and the recording will be made available. I will email those out as soon as possible. And please be sure to fill out the poll at the end. The webinar is geared primarily towards community health workers and frontline staff working directly with community members. We will first have a presentation on COVID-19 global vaccination efforts, where things currently stand with vaccinations across various low-resource countries, what has led to this situation, and what is needed to attain global vaccine equity. This will be followed by a Q&A. Today, our speaker is Dr. Bahuma Titanji, a Cameroonian-born physician and scientist currently based at Emory University in Atlanta, where she is an infectious diseases fellow. Her clinical focus is people with HIV, and her current research focuses on chronic inflammation as a mediator of cardiovascular diseases in people with HIV. She is passionate about global health and using science to influence health policy through science communication and advocacy. Our Q&A moderator today is Zizi Ahmed. She's a community health representative and navigator at the NYU Langone Health Perlmutter Cancer Center. She has several years of experience providing social services to and working in support of Arab communities in New York City. In addition, she holds a master's degree in art and archaeology from the Institute of Fine Arts at NYU. And with that, Dr. Titanji, the floor is yours.
Thank you so much for the invitation, and it's a real pleasure and an honor to be able to talk to this group today. It sometimes happens with technology, unfortunately, I'm having to use Zoom on my phone to deliver this talk because for some reason it just did not work on my laptop today. So Dina has very kindly agreed to help with advancing my slides. So Dina, if you don't mind putting up the slide deck, and then we can go on.
Sure. Mm-hmm.
So I've titled the talk today in name only, COVID-19 Vaccines and Failed Promises of Global Solidarity. Next slide, please. These are my disclosures. Next slide. And this is the outline that I would use over the next half an hour or so. So I would like to give the audience, to start out, just a brief summary of what the state of global COVID-19 vaccination and vaccine equity looks like. And then I'll spend some time going over the major drivers of why we are currently facing a COVID-19 vaccine inequity problem. Then we will talk a little bit about the implications of that inequity that we're currently witnessing. And I will close out with ways in which we can break the cycle and ensure that everyone is able to access equitably the resources that we have to fight and hopefully end the pandemic. Next slide. So we are currently in the third year of a pandemic that has been ongoing since 2019. And in that period of time, it's just remarkable how much harm the COVID-19 pandemic has caused. So far to date, we have recorded over 458 million cases globally, and over 6 million people have died as a result of COVID-19 infections. In the time that we've been dealing with this pandemic, fortunately, there has been tremendous progress in our understanding of what the virus is able to do and how we are able to prevent the virus from causing infections. We've also had remarkable progress in our ability to effectively treat people across the spectrum of both mild, moderate, and severe infections. And most importantly, just in 2.5 years, we currently have 13 approved vaccines, which are currently in use globally and have been shown to be quite remarkably effective in preventing the severe outcomes of COVID-19. So despite the incredible toll of the pandemic, we have had progress and we currently have the tools that should enable us to be able to end this pandemic. Next slide, please. Unfortunately, the biggest failure of the pandemic has been the failure to actually make these tools that have been developed for us to respond to the pandemic accessible in an equitable manner to people across the globe. And vaccines, which are one of the most important weapons in our arsenal, have been plagued the most by this problem of global equity in terms of access to resources. Now, in just the very short period of time that COVID vaccines have been available, we've done a remarkable job in getting them distributed to over 63.6% of people globally. However, when you look at who has gotten access and who has been able to benefit from vaccines, you realize that it's been heavily skewed towards wealthier countries that have been able to afford to buy the doses and also implement vaccination programs to make sure that these doses actually reach people. And at this point, it is estimated that only 14% of people who live in low-income countries have received at least one dose of COVID-19 vaccination, standing in stark contrast to 70% of people having received at least one dose of vaccines in high-income countries. Now, when you look at the question of additional doses beyond the primary series of vaccination, that disparity is even more stark. And the graph or the map to your right actually shows you what proportion of people across different continents have received additional booster doses. And as you can see, essentially in huge parts of Africa as well as Asia, booster programs have not yet been rolled out, really illustrating how much we failed in addressing equitable access to COVID vaccines. Next slide, please. So what's driving global COVID vaccine inequity? At the beginning of the pandemic, I think there was a wide acceptance of the fact that we weren't going to get out of the pandemic without having a global solution for what was a global problem. And a lot of the initial initiatives that aimed at addressing the issues of sharing resources, especially as pertained to COVID vaccines, were really targeted at initiatives that were meant to support equitable access of vaccines to low-income countries and to middle-income countries, which may not have had the same capacity in terms of production and procurement as higher-income countries. One of the main initiatives that emerged as a collaboration between the Global Alliance for Vaccines, CEPI, and the WHO was the COVAX initiative, which was intended to be an initiative that would facilitate countries that had limited resources to be able to get access to COVID vaccines through a global program that allowed equitable distribution of the vaccine doses that were available at the time. In addition to the COVAX initiative, countries also accessed vaccines for their populations through direct procurement and negotiating contracts with pharmaceutical companies that produce these vaccines. And there were also donation initiatives where high-income countries pledged doses to donate to lower-income countries that did not have. Countries like India and China and South Korea also proceeded with pursuing local production initiatives to produce their own local vaccines in order to meet the need. That was the plan. However, can you please proceed with the slide? When you look at what happened in reality, the COVAX initiative failed to deliver on its promise and its goal, which was to try to vaccinate at least 70% of the most vulnerable populations in all the participating member states in that COVAX initiative. And why did COVAX fail to deliver? They encountered defaults on donations to COVAX from high-income countries, and they were also faced by barriers to self-financing and procurement of doses through the COVAX program. Next slide, please. In addition to that, even the member states of high-income countries that were in agreement in participating in the COVAX initiative did not live up to their promises, but instead procured more doses than they needed for their own populations, resulting in vaccine hoarding by these high-income countries. And remember, there is a finite number of vaccine doses available globally. So if you had countries like Canada essentially purchasing vaccines worth more than the number of doses needed to cover 3 times its population, that inevitably meant that the number of available doses that were available to go to lower income countries was much smaller. Next slide. Lastly, there was lots of stalled progress in terms of addressing the issue around vaccine patents through the trade-related intellectual property waivers, which would have allowed lower income and middle income countries to be able to produce vaccines locally and by so doing increase the global supply of vaccines. Next slide, please. So just please, you can proceed with that slide. Yes, so in terms of additional things that happened, when you think about the donations that were provided to low-income countries, if you take the example of many countries that provided doses of vaccines that were very close to expiration, that didn't really allow low-income countries receiving these donations to implement a distribution strategy that fully utilized the vaccines that were donated. And at the same time, we witnessed across many high-income countries wastage of those vaccine doses that had been procured but didn't go into use. And there wasn't really a mechanism by which high-income countries could salvage these excess doses and donate them in a timely fashion so that these doses could be utilized in low-income countries. Next slide, please. In addition, when you look at the available vaccines that we have for COVID-19, the distribution is quite different in terms of who gets what vaccine. Now, we now know that, although the vaccines that are currently approved are highly effective in preventing severe disease and deaths, there are subtle differences between the different vaccine candidates, with the mRNA vaccines actually emerging as more highly efficacious vaccines when it comes to their ability to prevent severe disease and death. However, when you look at the distribution of these vaccines, you can see that not every country had equitable access to what is considered as the vaccines that have the highest effectiveness in terms of what the goal of vaccination is. In addition to this, some vaccines, notably the vectored vaccines, had very rare adverse effects that were amplified by the way in which they were reported in the press, further damaging the confidence in these vaccines, which for most part were the vaccines that were most available in low and middle income countries, further amplifying the issues of vaccine access and vaccine inequity. Next slide, please. So in order to get vaccines to people who need them, it is a lot more than just having available vaccines. The vaccines that you have on paper need to get to the ports of the countries where the target populations are. And once you have these vaccines within a country, you also have to consider how you get these vaccines into the arms of those who need them. And oftentimes, a lot of the vaccine strategies that have aimed to get COVID vaccines to low-income countries have been primarily focused on getting doses to the countries, with very little consideration being actually given to how we then fund actually getting those vaccines once they arrive at the ports into the arms of people who actually need them. Now, implementing vaccine programs, you need human resources and you need additional resources besides the vaccines themselves. Donations don't frequently come with syringes, and oftentimes you're asking the healthcare system within a country that is already stretched by its own pre-existing health issues to be the same system that then is also tasked with actually delivering these vaccines into communities. So unless you actually address the issues and what is needed at every phase of getting vaccines from paper into the arms of those who need them, you continue to see issues around amplified vaccine inequity. Next slide, please. Now, when we talk about, before we go into the implications of COVID vaccine inequity, I just put up this slide to really, again, drive home the message that COVID vaccinations have made a huge difference in the trajectory of the pandemic in countries where they have been readily available and widely implemented and utilized. In this very nice graphic that was put out in an article by Financial Times earlier this month, you clearly see the tremendous impacts that COVID-19 vaccination has had in the United Kingdom, which is a high-income country that has achieved about 80% vaccination coverage and also has a robust booster program. Next slide. However, when you think about the impact of not having access to vaccines, you can immediately see that at the phase of the pandemic we're in, where we are essentially dealing with a disease whose worst outcomes are entirely preventable by vaccination, not having access to those life-saving vaccines will amplify the excess mortality that we are seeing from COVID-19 in countries that do not yet have access to vaccines covering significant proportions of their population. In two recent well-done modeling studies, despite the fact that we have an estimated 6 million recorded COVID deaths so far in the pandemic, the true estimates, when you adjust for underreporting, actually puts the real death toll of COVID at about 18 million deaths over the past 2.5 years. And it's very important to recognize that every COVID-19 death, or almost every COVID-19 death that happens now, essentially could have been avoided by vaccines if we were able to get the vaccinations to those who needed them around the globe. Next slide. So it's clearly obvious that COVID-19 is driving increased deaths. Next slide, please. The second implication of not having access to COVID-19 vaccines globally in an equitable fashion, obviously, is the concern that not having ample vaccine coverage globally will drive the selection of more drug-resistant variants. Now, viruses are constantly changing, sorry, not drug-resistant variants, but vaccine variants that can evade immunity. Viruses are constantly changing all the time. And every time a virus has the opportunity to replicate and infect a new individual, that gives it another opportunity to change and to mutate, and increases the chances of selecting for future variants of concern. And through the waves of COVID-19 that we have experienced in the last 2.5 years, we have currently dealt with multiple different variants of concern, and not getting COVID vaccines to where they need to get to, and making sure that everyone is protected and has immunity that protects them from having severe disease from the virus, ensures that the virus continues to have the upper hand. And the result of that is that we're likely to see more variants of concern emerge in the future. Next slide. Next slide, please. The third implication of not having and achieving vaccine inequity, obviously, is prolonging the pandemic. Now, you can see on the graphic on the left-hand side of the screen that a bulk of the available COVID-19 vaccines have gone to high-income countries, leaving low-income countries behind. This essentially means that even if you vaccinate high-income countries up to 100% coverage of the population, so far as there are vulnerable people on the planet who can get new infections, we are going to continue to see new waves of infection emerge, and this would likely draw out the pandemic. Next slide. It currently feels like we are stuck in a vicious cycle of successive waves of the pandemic. And in order to really break that cycle, again, it's very important that we make sure that COVID-19 vaccines are available to everyone, everywhere on the globe. Next slide. We cannot close out the section on the implications of COVID vaccine inequity without addressing the implications of COVID itself on the control of other infectious disease conditions. Now, over the last 2.5 years, the pandemic has been incredibly disruptive for other important public health concerns. If you take the example of malaria, in 2020, we recorded 241 million cases of malaria, and there were almost just over 500,000 deaths also recorded. And you can realize that a lot of these deaths, the excess mortality that was recorded in 2020, was largely due to the fact that COVID-19 was extremely disruptive to malaria control programs in sub-Saharan Africa. The same story is mirrored with tuberculosis, which has also seen significant rollback in the gains that we have had with the control of tuberculosis and also with HIV. More recently, we are seeing, continuing to see the impact of COVID-19 disruption on immunizations for other diseases like polio. And recently in the news, there have been reports of wild polio infection in Malawi and also in Israel. Now, getting ahead of COVID-19 with vaccination and breaking the cycle of waves of the pandemic that continue to disrupt healthcare systems in developing countries would be a key piece in stopping the disruption that is impacting other infectious disease conditions and other sectors of public health. Next slide. We recently summarized, myself and other global health colleagues, the implications of COVID-19 for different disease conditions, and kind of also talked about how COVID-19 essentially is following a pattern that we've seen before with diseases like malaria and HIV, where wealthy countries have utilized resources essentially to control these diseases within their borders. And oftentimes, as we move out of the acute and critical phases, low-income countries tend to be left behind and continue to feel the impact even long after these diseases are considered no longer pandemics. Next slide. So how do we break the cycle and ensure that everyone has equitable access to COVID vaccines? I've summarized here some of the key points that I think are highly important for us to focus on as we continue to think about ways in which to break the cycle and ensure that everyone everywhere has equitable access to vaccines. Now, this list is by no means exhaustive, but I think touches on some of the key points that I would further expand on in subsequent slides. Next slide, please. Now, the first part of it obviously is advocacy, and I think that this is highly relevant, especially to this group, which is made up of mainly community health workers, and this is really in your realm, is advocacy talking about COVID-19 vaccine inequity and making sure that this is not something that gets swept under the carpet and becomes a forgotten issue, especially as we are moving into a phase of the pandemic where vaccine coverage in wealthier countries is much higher, and some people feel that the pandemic is on its last legs. So how can you do that? You can spread the word online and in your local community, making people aware of the inequities that still exist in COVID-19 vaccine access around the globe. And there are also opportunities to join the action, either through donating to efforts that are directed at helping fund vaccination programs in low-income countries, and I've provided some resources on this slide. And you can also reach out to your local politicians and urge them to do more in terms of tackling the pandemic, not only within your local community, but in terms of funding to support targeting and dealing with the pandemic more from a global standpoint. And you can advocate for vaccination within your immediate circles, either in your own community or for those of you who have family overseas, to your family members and friends who live in other countries. Next slide, please. So oftentimes people feel like, advocacy can take a lot of time to work, and sometimes it almost feels like it's futile, especially when you look at the lack of immediate results around you. However, throughout the pandemic, I think it's important to highlight that advocacy has been very important in terms of moving the needle around some of these issues pertaining to vaccine equity. Now, last year, kind of around November, Moderna, responding to the pressure mainly coming from advocates, stepped up to its commitment to meet up with the doses of COVID vaccinations that it had promised to the COVAX initiative. And it is results like this that are an important reminder to all of us that, although you may feel that you're not creating a huge impact by talking about the problem, ultimately the powers that be cannot ignore many voices, and advocacy is definitely a key piece in how we address the problem. Next slide, please. The second important issue in how we tackle this issue is we can't talk about global vaccine inequity without addressing what I think is the elephant in the room, talking about addressing misinformation and disinformation and vaccine hesitancy. Now, there is a common belief, which is not the reality, that there is more vaccine misinformation and vaccine hesitancy having a negative impact on low-income countries compared to high-income countries. And that even if vaccines become available to low-income countries, the uptake would be low. Well, there have been several studies, one of which I highlight on this slide, which have actually looked at levels of vaccine hesitancy across different countries and different settings, ranging from high-income countries to low-income countries. And the overwhelming evidence indicates that low-income countries do not necessarily have higher levels of vaccine hesitancy than high-income countries. However, there is vaccine misinformation, there is vaccine disinformation, and there is vaccine hesitancy everywhere. So whatever program that is targeted at addressing global vaccine inequity also has to have the resources to ensure that you're addressing the problem of hesitancy and misinformation in order to ensure that when the doses of vaccines do become available, that the uptake is good. Next slide, please. And you can see that it works. This is just an example of a tweet that was put out by WHO Africa earlier this week, highlighting the impact of a vaccine campaign drive in Kenya that involved not only sensitizing the population on vaccination, but also committed funding into addressing issues around hesitancy and misinformation. And you can immediately see that when you have a concerted effort to address these problems, it matters and it ultimately works. Next slide. In order to address the problem, we need continued and expanded pandemic funding. As we get into a phase of the pandemic where we are prematurely declaring the pandemic to be over and believing that COVID-19 is no longer a problem, what we have seen across high-income countries, including the US, is the announcements of cuts to funding directed at efforts to address the pandemic. And what's important to note is that as funding streams dry up in high-income countries to target the pandemic, there's going to be a trickle-down effect in terms of the fact that there will also be less funding directed towards global efforts that are aimed at addressing the pandemic. And the result of that would again be a situation in which wealthy countries with the resources will move on, and we will continue to have low levels of excess death that would be ongoing for many more years in countries that do not have the resources or access to the tools in order to address the pandemic within their own borders. Next slide. So what about patent waivers and TRIPS waivers? There has been some progress in that realm just this week, with global powers inching closer to an agreement to waive COVID vaccine patents. Now, waiving COVID vaccine patents, as I mentioned before, is an important piece of moving countries towards a point where low-income countries and middle-income countries are able to expand their own local production of COVID vaccines, and by so doing, able to meet the demand and break the cycle of the issues around insufficient doses for their own vaccination programs. The current agreement stipulates that potentially we could see TRIPS waivers mainly on vaccination that could apply for up to 3 to 5 years, but it would only apply to developing country members that have exported less than 10% of COVID vaccines in 2021. So China would not be included in these TRIPS waivers if ultimately member states of the World Trade Organization and European Union countries sign on and agree to this. It's going to be a huge impact in terms of making local production of vaccines more possible in a lot of developing countries. And I certainly hope that the agreement will go through and things would continue to move in the right direction. Next slide, please. Lastly, increasing vaccine production capacity in low-income countries is an effort that has been spearheaded by the WHO. And currently, there is a plan that includes 6 African countries being able to develop production capacity for mRNA vaccine technology on the continent. And this is tremendous progress because I think that it would certainly position low-income countries within the African continent, which currently imports 95% of its vaccines, in a better position to respond to this pandemic and to future pandemics when they do occur. Next slide. So what happens with the next phase of the pandemic? I think that we're getting to a point where it's really important to recognize that just saying that no one is safe until everyone is safe is no longer sufficient. It has to be more than a mantra. We really have to put our money where the change can happen and put our effort towards really enacting policies that will allow global vaccine inequity to be something of the past. And in order for that to become possible, you have to think about connecting not only what happens at the global level, but thinking about how you translate the resources that are poured into global initiatives into the local national initiatives within the country to allow the countries to utilize those resources to actually implement the strategies that allow us to target and fight against other problems of inequity, and also address on an individual level the issues around vaccine misinformation, disinformation, and hesitancy in order to actually increase uptake. Next slide. And I think that we are actually, right now at a crossroads in the pandemic where we can either choose to repeat mistakes of the past, so having country-centered strategies to target the pandemic, which will essentially prolong the pandemic for more months and even years to come, or get serious about having a concerted global response that is centered on equitable access to all resources that we have to fight this pandemic. Next slide. And with that, I would like to address my thanks to all global health equity advocates everywhere who work tirelessly every day to make sure that the important issue of COVID-19 vaccine equity remains at the forefront of the conversations around how we end the pandemic. And with that, I'll hand over to the moderator. I'm sorry about, again, the technical difficulties, but happy to take your questions. Thank you.
Thank you, Dr. BK, for such an insightful and thought-provoking presentation. It's clear that we have come a long way in this pandemic, but your discussion today brings home the point that we still have a lot of work to do. I also couldn't agree more with what I see as the essence of your discussion today with us, which is the point that, or the idea that, as much as many Americans like to think that we live in a bubble, the pandemic conveys just how global our world is. And put simply, we cannot escape this virus at home until the whole world escapes it with us.
or together. So helping low resource countries is not a work of charity. We're all connected and we're helping others so to help ourselves. So thank you very much. Before I turn to question, can you turn on your video cam or? Yes, hi.
Yes.
It's wonderful. Thank you again for the talk. So again, I'll turn to questions because we have a lot of them and hopefully we can address most of them today. So the first question is, one person wants to know if you can talk about any global vaccine efforts from the past that were maybe more successful that we can learn from.
Definitely. The first one that immediately comes to mind, obviously, is smallpox, right? The smallpox vaccine effort led to the eradication of smallpox, another viral infection that was a global problem. It was a pandemic, but essentially is also now one of the only infectious disease condition that we've been successful in eradicating. Now, one can argue that smallpox in itself, first of all, it's the mode of transmission is different from, say, for instance, the SARS-CoV-2 that causes COVID-19, and also the global population has grown significantly from the era of smallpox compared to the current era in which we find ourselves, and it's a lot more challenging to roll out a global vaccination program when you have 7.5 billion people on the planet, as opposed to maybe 3 billion or 4 billion people kind of around the time when we were dealing with smallpox. But that being said, that should not be a barrier to us having success with COVID-19 vaccines, because we have made progress in other aspects. Transportation is better. The interconnectivity of the globe is better. We are better at ensuring a cold chain for vaccination. And we also have our mRNA technology that allows us to rapidly go from a new pathogen to a vaccine in a very short period of time. So I think that what has changed between previous pandemics and the current pandemic is, I think that countries are just more inward looking and more focused on what's happening within their borders, and not necessarily thinking about global solutions for a global problem. With smallpox, it really took a concerted global effort and a buy-in from essentially every country to drive the initiative forward. And if you don't think about COVID-19 vaccines and vaccine inequity with that same urgency and put in that same concerted effort, you're not going to see the same results that we saw with smallpox.
Thank you for answering that question. So the second question is there any organization you would recommend for a financial donation to help on this issue?
On one of the slides that I showed, there's actually a link at the bottom, and I think the participants on this call will be able to access that link. It's the Global Alliance of Vaccine Initiatives link that allows you to donate directly to the COVAX initiative. And obviously, the COVAX initiative was initially created to help countries get vaccines, but now they're actually expanding, and Gavi also plays a huge role in sort of helping fund implementation programs to actually get these vaccines, once they become accessible to the countries, into arms. So that link on one of those slides will take you directly to the Gavi donation page, and you're able to reliably donate directly to the COVAX initiative.
The following question, the participant is asking, are there any job opportunities for community health workers wanting to assist in vaccine distribution in countries in need? It's a good summary written here.
I think a good place to start will be to look at those organizations that are actually main actors when it comes to the Global Vaccine Equity Initiative. Again, I would take you back to the organizations that are key players within the COVAX initiative. So CEPI, which is the Epidemic Preparedness organization, they are a key member of the COVAX initiative, the WHO, as well as Gavi, again, the Global Alliance of Vaccine Initiative. And under these big umbrella organizations, you can usually find much smaller organizations that partner with these organizations, which could have resources that allow you to actually participate in the effort at the level of your community. So those are good starting points or places to look.
Another question is, why are pharmaceutical companies allowed to maintain the rights to vaccine patents during global pandemic? What justification do they have for not waiving patents? What would be required for government to intervene to take away their patent rights?
Right, that is an excellent question. And I think I touched a little bit on that issue when I talked about TRIPS waivers. Essentially, obviously, when you ask why pharmaceutical companies don't want to waive patents during a pandemic, they do have a financial incentive, right? They develop vaccines and they are businesses, and their goal is to make profit. So when they have a new product that has very high demand, obviously, because it is the business model, even if it's not the right thing to do, they do have a business plan that is largely driven by the need to make profits, and that in itself is a whole talk on its own. However, when going back to the question of why are they allowed, well, essentially, when you develop a new product, you have a patent on the product, and current global trade regulations do allow you or allow these companies to hold on to their patents. That's why we're talking about TRIPS waivers. But in order for the companies to be required to lift those patents so that their products can be produced by other companies, you have to have the approval of the countries that sign into these agreements. And that has been a huge issue during the pandemic, with some countries being in agreement to waive TRIPS waivers. Notably, the US has been in support of that, but lots of countries within the European Union, like Germany, and other countries outside of the EU, like Japan and Australia, not being in favor. So people have to be in agreement that it is the right thing to do. And I think that we are making inroads, which have largely been driven by the advocacy of lots of voices calling for this. And I just showed you the latest progress towards an agreement of at least getting TRIPS waivers on COVID vaccines. That is the first step. And hopefully, once that is done, we may see an expansion of the waivers extending to testing as well as therapeutics.
Thank you. So the follow-up question is, it does seem that a lot of people are moving on from the pandemic. In the event that we are unable to really address the issue of global vaccine inequity, what do you expect in terms of the future course of the pandemic? What the worst outcome could be?
I'm not one for predictions, because I think that I've been burned enough times in the course of the pandemic to have learned to be very humble in the face of this relatively very new virus that we are dealing with. But I would say this, even if high-income countries move on from the pandemic and declare the pandemic to be over, my biggest fear is that essentially we will revert to what we have seen happen with other diseases which were once global pandemics, like malaria, like TB, like HIV. Essentially, it would no longer be a pandemic of wealthy people. It would be a pandemic that only affects the poor. And we run into the situation where we are likely to see ongoing deaths or excess deaths in the most marginalized and the poorest strata in society. So we have to learn from mistakes that we have made in the past, which is why I talk about how we break the cycle and ensure that we don't just continue to do the things that we've done before, which clearly have been bad and have not benefited the most vulnerable amongst us, which we should be protecting.
Well, that exhausts all of our questions today. Once again, before I hand the mic to Dr. Freeman and Dina, I really want to thank you for taking the time to be here today with us and share your expertise. And thanks to everyone who attended the session today, especially those who participated on sent in questions. So thank you very much.
Thank you. Thank you for having me.
That was really amazing. I'm not sure if I'm on video or not, but my name is Amy Freeman and I direct the Community Health Worker Research and Resource Center. And I apologize for our technical issues today. This just was one of those days, I guess. But your presentation was just so just insightful and yeah, I mean, concerning too. Like, I feel like this is an issue we all really need to be paying more attention to. And, you know, not just in words, but in actions. And I just really appreciated the knowledge you shared with us today, your time and your expertise, Dr. Tatanji, and Zizi for doing a wonderful job moderating, and everybody for attending. We will be sharing the slides and the recording early next week. And I also want to thank my other colleagues at the Community Health Worker Research and Resource Center, Rajesh Vedanthan at the Section for Global Health, and Nadia Islam and Sarah Hussein at New York SEAL and the Prevention Research Center. You should be seeing a poll pop up on your screen. Please go ahead and answer just 4 questions. This helps us make sure that the events we put together are useful to folks, and stay tuned. I apologize if we didn't get to every single question, but again, thank you, Dr. Tatanji, so much for sharing your time and expertise with us, and Zizi for your wonderful moderating.
Thank you.
Did I forget anything, Dina?
Nope, that's all. Please stay tuned for an email with the recording and the slides, hopefully next week. Thank you.